If I were to ask you a question, if you had £1 million and you were in charge of treating two groups, the first of which is 100,000 stomach ulcer patients. The second one is a cancer patient. Now, who would you choose to invest in the treatment? But keep in mind that if you invest in one, the other one dies. I would personally choose the 100,000. Who else agrees with me? Well, the majority of you, which is actually really good. So what you have all experienced is something called a totalitarianism concept, which is basically choosing the lesser of two evils, the lower of the losses, the one that costs less. But let me spice it up a bit. Let me say that you also have £1 million, that the 100,000 stomach ulcer patients are there, but the cancer patient isn't just a cancer patient, it's a family relative. I've seen some people starting to, yeah. You all are thinking about it. Nah, I'm not going to invest the whole 1 million in the 100,000. Maybe 25, 75%. Maybe just £1. Now, what you have all experienced is actually something called subjectivity, in which we all are seeing different pictures. We all have different values of it. Value. And instead of just seeing one, you're seeing a relative. You're seeing a core value. You're seeing someone that you love. Now, as a pharmacy student, I was actually really interested to know how do healthcare systems just keep up with being objective at all times, under all the stress, under all the management. After all, in the one of the 4 bioethics of health, justice is one of them. Treating all people fairly, regardless of race, color, creed, relationships. And whether it's in the pharmacies of Cairo, the hospital of Kajang in Malaysia, or the hospices of England, they all want to have one goal: making you all healthy. Whether it's in picking up our bucket lists, increasing our cultural intelligence, or living life, we all want to be healthy. And as I kept on studying and studying more in my pharmacy degree and kept up with all of this and reading more about it, I started learning more about stuff about how did they always stay objective. For example, when I was young, I always wanted to be a doctor. And the reason why is because I thought that when I was sick, I was just prescribe myself a medicine and that's it. But apparently, doctors are not allowed to do that. In terms of like pharmacists, for instance, if a pharmacist and a patient do develop feelings for one another, they must always signpost them to the nearest pharmacy, because it always impairs your judgment in always seeing the objective picture. Instead of just seeing 100,001, you're seeing 100,000 and a picture. Now, I'm going to give you one last example of how does it actually happen. This example is really sciencey, so you all must really focus hard on it. So, when a drug company wants to get out with a drug, what happens is they keep up researching the disease. They want to know more about it. They come up with a product. We go through phases of trials, of examinations of how it's going to be active. And after all of that, if it is successful, after the phase 1 trials, phase 2 trials, and the phase 3 trials, they submit an application to the health regulatory agency here in the United Kingdom. And after that, if it is successful, it goes to this organization. called NICE. Now, NICE is a very close organization to my heart because, first of all, it stands for the National Institute of Health and Care Excellence. And what it does is that it gets all these medicines and starts to do an economic evaluation. So, if let's say I'm going to treat depression, one medicine in treating depression is called citalopram. It's an SSRI. Another one is called amitriptyline. And what NICE does is that it gets the cost of treating with these two drugs. So for instance, I'm going to put citalopram here and my amitriptyline here. And in these decisions, they say, well, what if treatment is unsuccessful? And so they say, maybe we're going to increase the dosage of the citalopram, of the medicine. And then they calculate the cost in each of these three diagrams. This is called a decision tree analytical model. And then after that, after calculating all these costs and all these outcomes, they develop something called an ICER. An ICER stands for incremental cost effectiveness ratio. And what it does is I put things into perspective. This is very economically. So let's start with this. So what they do is that they start plotting the ICERs on a graph. In here you have the outcome, in here you have the cost. If for whatever reason the drug is in this quadrant, this means that it is a more favorable outcome and it's less costly to them. And so it's a dominating drug. And so most probably it's going to come out. If the outcome is less or less beneficial and it's more costly, it becomes a dominated drug, which means that it most probably won't come out. But again, we're always sort of realizing that there is also a subjective decision making that also in this process. Because what if the drug does give a better outcome, but it's also more expensive? What if the drug gives a less outcome, but it's cheap? So what they do is that they sit all down together and they start analyzing the market. Do we have a better outcome? Do we have another substitute? And you might be asking yourself a question. Why am I telling you this? Well, it's all because of one word. Patient. Now, a patient in general is someone who receives healthcare. This has always been the definition ever since the beginning of time. But as technology came to be, that definition started changing a bit. I'm going to give you an example of something that's really unrelated to medicine a bit. Commercial airliners, for instance. 20 years ago, what you would do is call up a travel agency, book your ticket, you would print off your ticket, print off your boarding passport, and they would check you in. But when was the last time you did that? When was the last time you had a paper ticket with you? When was the last time you said, hello, yeah, I want to go Madrid? Yes, thank you, sir. And you kept on trying to talk to a person. So what commercial airliners did was that they started saying, yeah, well, a human being can do that themselves. They can print out their own tickets. They can reserve it themselves. And so we would cut the cost of all of those things. Because when you think about it, reflecting back on healthcare, the most underused resource in the whole equation of healthcare isn't the pharmacist, isn't the doctors, isn't the nurses. It's actually the patient. And so Right now, what's happening is that patients are going to become in more control of their own healthcare themselves. You might be doing this yourself, the economical evaluation yourself, and you're trying to become more objective towards your own healthcare. You might be using this smartphone right here to measure up your heart rate. Put a $20 sensor on it. That's a heart pressure sensor. Use a simple algorithm. You might have just invented the very first phone that can call the ambulance whenever you have a heart attack. And so, this is called the democratization of healthcare. When, as one of my favorite authors, Eric Topol, says, doctors are becoming more and more dictated towards the healthcare information. And so, what you have is that stars are becoming together, as in this theme. Stars as patients, they're all becoming connected to each other. They're all becoming more and more concerned with each other. This even redefines the whole definition of health as it is. It becomes even the more mere definition of health becomes even more subjective towards it. And when you think about it, you might be asking yourself this question in the future. What if you have £1 million? And this £1 million can either be used in the treatment of 100,000 stomach ulcer patients, or in one patient. But this patient isn't a cancer patient, isn't a relative, it's you. Would you invest in yourself? Thank you so much.